Oh, hello, Candice Lamb.
Hello, Amanda Wilson.
Hello, Lauren.
Not quite ready yet.
G'day.
Welcome.
G'day.
Welcome to the podcast. First ever time we've had a... What are you?
I'm a GP.
A GP.
Totes professional GP.
A totes professional GP.
Maybe the coolest GP I know.
Oh, gosh. How many do you know, though?
I know a few.
All right.
Yeah.
Nice.
You're up there. You're up there.
I always wanted to be the cool kid.
You did it.
Today's your lucky day.
So is it.
I've already asked you both, but how did we get here? How do you know each other?
When I was working in the clinic, I used to see a lot of your patients, a lot of your women's health patients.
Yep.
And then you were one of my patients after you had your first baby, Hattie. How many years? How old is she now?
7.
Jesus.
We go way back.
We go way back.
That's
way
pretty
back.
cool.
Yeah.
And then she left.
Yeah.
Oh.
And the dynamic between, like, how do you go, I'm going to refer to Candice? And is that just like feedback from your previous patients and then you keep sending them to Candice? Like,
like how did I start sending patients
Yeah,
to you? I don't really remember.
Maybe did I come on a visit or something maybe, or
Oh,
I don't
visit
even
the
know.
clinic? No,
Maybe.
don't
Don't
know.
know.
But
The
I mean, we're
schmoozing?
talking
Yeah.
like 10
Yeah, it was a long
Yeah.
time ago.
years ago.
Long
or
time
something,
ago.
So,
yeah.
yeah.
That's a long time
Yeah,
ago.
I know, isn't it?
I would have been a real shit physio then too, I reckon.
Oh,
Can't have been that shit.
I mean, the stuff that you learn, I think we're here to talk about menopause and perimenopause today. And I think, apart from there being so much more knowledge about that, I think I probably would have given some pretty rubbish advice back then.
Sorry to all the old patients.
No, like genuinely, we know so much more about it.
Yeah.
But I don't know that I was I've been a GP for 15 years now, so you pick up a little bit along the way, especially specialising in women's health, so seeing heaps of that stuff.
So that's what you do, specialise in women's health?
Yeah, so I mean, I'm a general GP,
Yep.
general practitioner, but like families and women's health has always been my specialty. I did my diploma of obstetrics and gynecology over in Western Australia before I started at the start of my GP training. So used to do looking after pregnancies and delivering babies and stuff. And that just is too hair raising for me in a tiny little town, being like the one doctor at a birth. So I moved more away from the practical stuff and to women's health in general practice.
I got to know, when you deliver a baby and you go home, how long does it take you to wind down from that?
Well, it used to be a lot. So I was working in Bustleton, which is this little 10,000 person town in Western Australia. It's beautiful, great place to live. But yeah, like the next, if you need an emergency Caesar, like you're calling in the entire staff and starting up the, surgical suites. And it's not like being in the city where you're like, this person needs a crash Caesar and and 5 minutes later you got a baby out. So that's pretty hair raising, that kind of stuff where you go, oh my God, you could have 2 sick patients that, you can have a mum who's just given birth and bleeding and then a baby who's got respiratory distress and there's one of you and one midwife. And so, yeah, that wasn't for me.
Yeah.
It wasn't for me. Props to all of the rural, especially the like GP obs out there in rural land, because I couldn't hack it.
Fair enough.
But wanted to stay in women's health.
Yeah, definitely. I mean, I love that stuff. And I think over time too, like I was really passionate about pregnancy and early family life. And I think as time has gone on, I've kind of veered more the like gynae side of things and got more interested in periods, pelvic pain, hormones, perimenopause, menopause, that kind of group of stuff.
And then how often are you learning new things? Like you said, there's new stuff coming out all the time.
Oh, like constantly.
Yeah.
Yeah, it's just. So certainly, I mean, we have to do a certain amount of CPD each year for our professional board. And so I think a lot of that for me ends up being women's health, because obviously I'm seeing a whole lot of that. So there's conferences and podcasts and all kinds of stuff that's just constantly being produced. So professionals who have an interest in menopause can be members of the AMS, the Australasian Menopause Society. And incidentally, if you're looking for someone who has an interest in that, that's a good place to have a look at. They've got a list of practitioners on their webpage who are aligned with the AMS. And so they put on, like, there's an annual conference, and there was a half day event down in Brizzy the other weekend that I went to, and yeah, it's really amazing.
That's cool.
Women's health is finally having its time.
Yeah.
We're all like, yeah,
Finally.
endometriosis and pelvic pain and all of this stuff that's like, it's real and it's finally coming into the spotlight. So I'm thrilled to be on this.
It's
So good.
Yeah, so cool that you're all in
when,
it.
when Candice sent me a message and was like, hi, do you remember me? I was like, yeah, clearly. And also we do this podcast and do you want to come on it and talk about menopause? And I was like, yeah.
She's like, how many hours can we talk for?
Yeah.
Well, I got school pickup, so not too many.
Yeah, not too many. I'll be watching
Rein
the
me
clock,
in,
don't
man.
worry.
I'm passionate about this.
Awesome. So what are we going to go
Yeah,
with?
so we are going to talk about menopause today. So I guess a bit of our gym background. I should have looked up our average member age. Do you know it off the top of your head? No.
I actually think I saw it the other day. It's between 35 and 40, I think.
35
Yeah.
and 40?
Yeah, I was looking at something on Push Break.
Yeah, cool.
It's usually me.
Your age, yeah. We just have had a bunch of women over the last probably like 6 to 12 months who are kind of getting into that menopause period, and lots of symptoms of that popping up before they're even really aware of what's going on. And us trying to talk them off the ledge and being like, you actually need to go and see someone because I think this is what's going on. So I think just today we want to touch kind of broadly on what is menopause, the symptoms, treatment options, all of that kind of stuff. And if we go on any wild tangents, we'll just strap in and see where we end up.
So let's start with just what is menopause? Let's go with that.
So by definition, menopause is the last period, but you don't really know that until you've had 12 months with no periods. So that is a retrospective diagnosis. Once you get to that 12 months with no period, then we look back and we go, yeah, menopause was from that last period, and anything up to that is menopause transition or perimenopause, and that includes that 12 months where we're twiddling our thumbs waiting to see, is that it? Or
Is it coming? Is it not coming?
Yeah, and so of course that's trickier when women don't have a uterus or they have a marina in or something where you don't have periods, but that's our like broad definition. Once you hit that 12 months of no periods, they're then considered postmenopausal. And essentially it is the ovaries shutting down. They've run out of eggs. When we're born, we have a certain number of eggs, thousands of them actually. And each month, you ovulate and get rid of an egg, and a whole bunch of eggs otherwise die. And so the starting up process, when we're starting to get periods, can be a bit rocky and hormones all over the place. And same thing when it's ending on the other end of things, where the hormonal balance starts getting a bit more out of whack, and we see periods doing different things. They can be longer and heavier and lighter and have funny spotting here and there, as well as all of the other hormonal changes that can happen. But essentially, once the ovaries have finished ovulating, they shut down and they're done. And most of what the ovaries do is, apart from producing an egg, on a hormonal side of things, is producing estrogen and progesterone. So there are two key, like, women's hormones that have receptors all over the body. So, everyone would be familiar with some of the symptoms we see around even changes in your cycle and how that affects you. So we see all kinds of symptoms related to peri and menopause.
Is it as straightforward as 12 months and then you're done? Can you bleed again after you've had 12 months of no period? As in, like...
You can, but if it's after that time, then we definitely investigate it. Once it gets to about 10 months or so, if you then start having bleeding, then it sort of starts ringing alarm bells.
So not common after?
No,
yeah.
Look, there are these women that get to like 6 or 8 months and you're like, yeah, it's probably done, and then they will randomly have a period or two. Psych! Wasn't then. And there's these other women who just, have pretty regular periods. Maybe it goes a bit wonky for 1 or 2 cycles and then it just stops and they're like, oh, well, that was it. So that's the 2 extremes, but for most they sit somewhere in the middle.
Yeah.
So that perimenopause period can be sort of 2 to 8 years. So, we always...
That's a long, like,
Right,
8, that's a
isn't
big
it?
spread of years.
Can you imagine? You can. And so in that time we start to see higher FSH levels from the brain. So that's the hormone from the brain that's stimulating the ovaries to produce the hormones in the eggs. And we see really variable estrogen levels. So you can have sometimes where it's really spiked and other times where it's really low. But overall, most of the symptoms that we get around perimenopause are from a low estrogen state. We start running out of it.
So people can start experiencing that up to 8 years before they actually go through menopause.
Yeah.
Rude.
Yeah. Right? And I think traditionally we were like, oh, yes, that like year or so before period stopped, they can get a bit funny and maybe women get a bit hormonal, get
It's a bit
moody
crazy.
with that.
Yeah.
But that's about it. And then, they get some hot flushes and that's about it. That's all. That's menopause done. And now we really understand that those changes can start a long time before. Oh, and I also should say, in terms of what we consider normal menopause, that's sort of 45 to 55 age group. Average is kind of 50, 51. Anything under 40, pretty rare, about 1 or 2% of the population. That's primary ovarian insufficiency. And early menopause if it's at 40 to 45.
Mm-hmm.
So if the symptoms go for 8 years, though, does that mean the menopause is done at like 50 on average? So you can experience the symptoms as early as 40, though? Is that what you mean?
No, so that's like for it stopping. So our normal menopause is that 45 to 55 age range. So if you're starting to have, in your late 30s, you're starting to have period changes and longer cycles and a bit spotty and funny stuff. I mean, obviously that needs investigating, but certainly then we're thinking, okay, you're going to go through menopause at like 41. That's way too early. That's not what we expect. We were just never designed to live a really long time without, especially estrogen on board. Like, back in the cave days.
We'd be dead by now.
Right, you would. You'd probably have infected tooth abscess and die, or
Killed by a
copper
saber-tooth.
spear, or right, exactly, just starvation.
Yeah.
And so, I mean, if you go through menopause at 45 and you live to 95, I don't know what the average is these days, but again, get into the 90s, that's more than half your life without estrogen. So,
Good for nothing back then.
Not making babies. What good are
What are
you?
you good for? Can we talk symptoms?
yeah.
So, like, what are the symptoms?
I mean, pretty much anything.
Anything.
Literally anything you can think
Anything
of.
that sucks?
Pretty much.
Could be, anything that's a bit shit.
Yeah.
Ingrown toenails? No. So certainly, I mean, we can see skin changes, so dry skin, hair fall, thinning hair, oilier scalps, even though it can get drier.
Could be one of two options.
Yeah. Obviously, the big ones like fatigue is a really classic one there.
That's what we see that a lot, like the women in the gym.
And
just
issues
like,
with
I
sleeping,
just
I reckon. Like,
can't do anything.
yeah, tired in the gym and problems with sleeping.
Yeah.
They're the two biggest
Yeah.
ones that I see with the girls.
And insomnia is a big one. So certainly we can see insomnia related to vasomotor symptoms. And vasomotor symptoms are the night sweats and hot flushes. So all of the blood vessels dilating, trying to give off heat. Part of that low estrogen state is that we're more sensitive to heat changes. And so a tiny increase in temperature and the body's like, whoa, cool down. And so, dilates all of the blood vessels so you can give off heat, which is like, sure, that's great, except you're flushing and drenching through at nighttime. So insomnia can be related to that, and it also just can be on its own, where it's not that you're hot or not necessarily that you've got things running through your brain. You're just waking up at kind of 2-3 a.m. is the classic, and just twiddling your thumbs, just not tired. But
Rude.
of course then tired the next day. Rude.
Very, very rude.
What else do we see? Obviously reduced fertility. So we start seeing that from kind of mid 30s. So once you sort of get into late 30s, early 40s, like things start getting tricky there. It's one of those, it's one of the things we check if your periods stop, is like just making sure you're not pregnant actually. We certainly see, so that it's this group of symptoms that we now call genitourinary syndrome of menopause. And so that's all of the pelvic stuff. That's the genital dryness.
It's my bread and butter, this stuff.
Right. Reduced secretions. So like dryness, irritation of the genitals, painful sex. We see higher rates of urinary tract infections, irritable bladder kind of symptoms, this overactive bladder where it just feel like you need to wee all of the time.
So it just got more rude.
Yeah.
We're
Yeah.
highly rude
Yeah.
level.
Very, very offensive now.
Yeah.
pelvic floor dysfunction. Like obviously, you know a lot about that. Where it's not just that you know, an irritable bladder or some dryness. It's that actually the tissue of the pelvic floor itself is affected, and so your ability to, you know, squeeze and lift and all of the things that pelvic floors are meant to do becomes trickier. What else do we see? Oh, loss of muscle mass. That's a key one. So this sarcopenia that we call it.
Not in these parts.
Yeah,
Lauren.
well, I know. Look, this is just an ad for CrossFit Contessa now. Bone density, of course. So certainly that.
Is that linked to menopause? Like,
Definitely.
Yeah.
Yeah. I mean,
Why?
there's so much.
Estrogen.
Yeah,
of course.
So it's one of the drivers of, bones are constantly being broken down and built up, and the ratio between the two enzymes that are doing that determine whether you're like building bone mass or losing bone mass. And from our bone mass peaks in, I don't know the stats now. It's like late 20s or something there, and sort of gradually does this decline. And then once you take estrogen out of the picture, it can do quite a significant drop down there. And there's genetic factors in how fast it does that. But yeah, again, we were just never designed to live for like decades and decades without estrogen on board.
So I know with like the bone mass and muscle decreases over time after that 30 if you don't lift weights. But menopause would then accelerate that even further because of the dramatic drop in estrogen.
Yeah.
Interesting.
Because over the space of a few years, you go from quite high, you know, variable, but quite high circulating levels to, I mean, really bugger all.
That's crazy.
Yeah.
Medical term, bugger all.
Bugger all.
Yeah.
You have bugger all estrogen.
Official.
So it's professional.
Pinged off.
What about like cardiac health?
Yeah, so that was the one. I mean, we spoke about that a bit. So this is a big one. That's why, you know, groups like you guys are so important, because this.
Another plug.
Say it again.
Well,
Say it slower.
because we see so much that we want to, if we can keep health now going forward, we see so many less issues. So in terms of vascular health, so estrogen plays a role in a whole lot of different ways. We see after menopause, we see significantly higher rates of all kinds of vascular disease, so heart disease. So women are behind men in terms of rates of heart disease until you hit menopause, and then up they go, and not quite, but almost join men on there. So estrogen affects the lining of the arteries, keeping them healthy. It's an antioxidant, so it's stopping damage from, you know, free radicals in our diet. We see, so when there's low estrogen levels, we see higher rates of the lipids, so all your cholesterol, triglycerides all go up there. We see high rates of diabetes, blood pressure tends to go up. You tend to get, so it's this metabolic syndrome, we call it, where you tend to put on weight on your tummy. What else is associated with it? So in terms of like the other vascular stuff, we see high rates of stroke. And interestingly, although we haven't seen it in standard menopause, but in women who have either early menopause, so this premature ovarian insufficiency in the under 40s, or women who have surgical menopause, so they've had to have their ovaries removed for whatever reason there, we see all of this cognitive stuff. So we see high rates of Alzheimer's disease and Parkinson's disease. I didn't know that one until this morning, I have to say, when I was looking it up, which you can reverse by having them on hormonal therapies. So, I mean, all of your listeners, I'm sure, will be aware of all of the cognitive changes that we see. So
like brain fog is a big one that's reported
so like brain
in
fog,
the gym, huh?
Yeah.
Yeah, so brain fog is really working memory and that sort of concentration and focus there. So, I mean, estrogen in the brain is responsible for levels of serotonin, which is like our, you know, mood kind of chemical, and for dopamine, which is our reward one. So all of the like motivation, get up to do something, actually finish a job, all of that stuff. And so, I mean, this fatigue is like everything seems hard, because it is, because your brain is having to work heaps harder for that stuff.
And then like the mental health implications of that are huge for people, because they're like, I feel like shit. I don't want to do anything that makes me feel better. You get stuck in this like cycle.
Yeah. So we spoke a bit about, of course we see all the mood stuff, rage, and that's like
I experienced rage already.
You are in trouble.
I'm going to go to jail.
there's no hope for you, Mary.
I'm in trouble.
Do you know, we amongst my friends were like, I can see why, you know, in medieval times there were witches who just like
They're like,
a bunch of
"Fuck
them
you
went
all."
just went into the forest and like lived their witchy lives. And, like,
Maybe that's what we'll end up doing.
100%. I'm off.
I'm all for it. It's like, see ya. Bye,
I'm a witch
everyone.
now. Bye.
Yeah.
Put curses on everyone.
Deal with society. You guys all suck.
Yeah, I get that.
Makes sense.
So yeah, obviously high rates of anxiety, depression, people who have never had it before. Certainly if you already have, so if you've had postnatal depression or, you know, your standard depression diagnosed previously in life, you're much more likely to experience that around perimenopause, the joys. And
Things are not
menopause.
sounding
You
good.
are like, when you
Really
said
talking it
every
up.
symptom, you really,
Yeah.
it's like everything, hey.
Oh yeah, joint aches and pains. Like it's
Great.
I mean, it's pretty much every system.
And then,
yeah.
so back to the metabolic health stuff.
Yeah.
And even as far as the belly fat, you said that people, you know, that happens. Even if they continue what they've always done, they can find their health decline rapidly again from this.
Yeah.
It's crazy to me, hey.
So frustrating for patients that come in and they're like, I'm eating well, I'm doing all of this exercise and still this weight gain.
Yeah.
And it's a bit like, that's
what it is, baby.
Sorry.
half a kilo a year over 10 years is the kind
Yeah.
of classic traditionally spoken about, which I think is probably, I mean, that's data from years back. So I think it's probably going to be more than that these days.
For sure.
But yeah, no matter what you're doing. Okay, this is sounding really depressing. The good news is that you don't have any periods, so
You can't get pregnant anymore.
that's
So
right.
who's the real winner here? Not us.
Unprotected sex. Don't get a disease, though. But
That's right.
it's a whole other problem.
God damn.
So, but like you said, if this is why this sort of stuff, lifting weights, staying healthy, that's why this is so important.
So the lifestyle stuff. I mean, in anything where we're going to start talking about health is going to be the primary thing is going to be lifestyle. You know, getting enough sleep, doing physical activity that makes you feel good, and especially any of that muscle building, weight bearing stuff for the, you know, bone mass and muscle mass there. Not too much booze, like that's a really key one. Not smoking, preferably, obviously, for obvious reasons.
Is the alcohol something that you have to talk to people about a lot?
Yeah, and I think
Rip the alcohol bottle out of their hand, the wine bottle.
well, and wine is a hard one because it's in a set amount and it's really easy just to drink a bottle rather than having to, you know, pour a glass and then you pour, you know, another.
And then it goes
glass with a
bad, so you just don't want to waste it, you know.
Yeah, so once you
Better drink it all.
and you know, a standard bottle of wine is 7 to 8 standard drinks, and so that's like your entire week's worth of alcohol in one go from there. And I mean, you could get into stats, but you know, things like stuff we start thinking about in terms of preventative health around this age is like people who drink more than 4 standard drinks a day. We see much higher rates of breast cancer associated with that. So, you know, it's not just that kind of social aspect to it. It's really ingrained into lives, and it doesn't have to be enormous amounts. It's not like, oh yeah, you get through half a bottle of gin a night. Like that's obviously really problematic, but even smaller amounts can be. And in terms of energy and pep and zing and all of that stuff too.
What was that last word you just said?
Zing.
Yep. Oh, yeah.
Zing.
Another
Pep.
medical term.
Yeah, that's right. Totes professional.
Pep and zing. I thought it was some word I've never heard before. Never mind.
Not from a doctor anyway.
Like I said,
I got
cool
confused.
doctor.
Yeah,
Can you,
doctor.
sorry to interrupt, can you just turn that, see that little arrow up there? Could you press it down 2 times? I'm sweaty.
Are you?
My pillow's making me sweaty.
Oh, you got too many.
Yeah.
I can feel happy.
Are you hot as well? Too much knowledge in that brain.
Just working too hard.
It's the menopause. Well, you know, it starts becoming more personal when you are then a woman in your 40s and you're like, oh, hang on a sec. So as like with anything, you start taking an interest in in things that affect you more.
So interesting. And then when you were just listing off all the stuff, especially to do with the fitness side of it,
Yeah.
I was thinking about people like Rach Robinson, who is a friend of ours that just qualified for the CrossFit Games again, who's in the 50 to 54 age category.
Nice.
I'm like, how has she been going? Like, I'd love to talk to her about like how she managed this entire last 10 years of training, because she's been an athlete her whole life.
Yeah.
But I can imagine that would have been
Had a huge impact.
tricky.
And kind of touched on it, but musculoskeletal injuries pop up a lot. So estrogen helps with our tendon health particularly. So we start to see, and I know Rach has struggled with this, shoulder injuries, hip injuries, Achilles injuries, like all those little niggles start to get bigger and bigger. So I wonder if it's just about managing that kind of stuff.
And this
those
is what they
women.
say with masters athletes, as Bex would know. She trains our masters ladies around these parts. Less volume is better.
Yes,
Like,
yeah.
In terms of CrossFit, it's like lower the volume, increase the intensity.
Yeah, and like focus on
relevant.
good movement patterns so we're
Yep.
not putting those tendons at risk
Yeah.
any more than they already are.
So interesting.
So many things.
So many things.
Yeah.
Can we go into this is nothing, I know nothing about it, but I do know that Candice is quite passionate about it, and I hear a lot of objections to it. The hormone replacement stuff. Why do people not want to do it?
So there's an ongoing study in the US called the Women's Health Initiative that has several parts to it, different things that they're studying. Started in the late 90s. One of the sections that they were looking at was HRT, or now we know it as MHT, menopause hormonal therapy, because everyone just loves changing names on things for no good reason, apparently.
Like there's more important things to focus on.
They're like,
just not call it HRT.
like hormone, menopause.
Yeah. So that arm of the study, the HRT arm, they stopped in the early 2000s because they had concerns about some of the health outcomes there. And so rates of HRT use of the world around the world dropped to like 30% of what it was previously, because they were like, oh, it's going to give you it's high rates of heart attack and high rates of breast cancer, and there was just this huge scare about it, and everyone just went and stopped using it and prescribing it. And I think we're still crawling back from that, really.
And when was this? 2000?
So that was early 2002, I think that
Wow.
came out there.
30 years later.
And I think the hard thing is, like, a lot of the data that we're using is also based on that. And they were looking at a very specific combination of equine estrogen, so horses. Wee, that's right. And they just get the estrogen out of their wee. And one of the old synthetic progestogens. So the kind of medications that we have these days are so different to that. We've got so many body identical hormones now. So it's, yes, it's made in a lab, but it's exactly what progesterone looks like in your body, or it's exactly the same as the estrogen that your body produces there. So it doesn't have those same risks associated with it. We've got different ways of doing it now. So all the transdermal stuff through the skin, patches, creams, gels, also a lot safer there. So the tricky thing is, a lot of the data we've got is based on that very specific single combination that absolutely no one is using these days. I
Yeah,
can't
so
think
people
of
are scared of like a result that doesn't actually even apply anymore.
Yeah,
Like
to these newer
Yeah.
ones where, for instance, the rate of clots, right, blood clots, which is associated with the oral estrogens. They swallowed tablet versions of it there is a slightly increased risk of blood clots with that. So we see slightly higher risks of stroke, heart attack, DVTs, blood clots in the legs there, which in an otherwise healthy 50-year-old, when your overall risk is quite low, even if you look at 1.7 times that, we're still looking at pretty low risk stuff. But anyway, on a big picture, when there's thousands and thousands of women on it, that makes a difference. So using that instead as a transdermal route, you basically obliterate that. And so now, like, for instance, women who have had a stroke or a heart attack, where in the past we were like, no hormones for you whatsoever, too risky. Low doses of transdermal estrogen are actually quite a reasonable thing to try. So, that's wild compared to what we thought 20 years ago when all of this scare stuff came out about it there. breast cancer risk, again, mostly associated with these older progestogens, so these older group of medications that were then turned into progesterone in the body, and so the newer progesterone itself doesn't have that significantly increased rate of breast cancer risk that we see with those older ones. There, it's probably a tiny smidge more. Some studies actually have it having a lower risk of breast cancer. So it's still pretty new though. We don't have 30 years of data on it like we do with the older stuff, because it's only been around.
This may not be comparable at all, but sounds to me like the symptoms of like the pill, like the birth control pill.
Yeah.
It's like is it comparable in terms of potential risks? As in, like, no one's scared to take birth control, but they're scared to take this. Is it like...
Well, they kind of are.
Yeah. They are?
They kind of still are.
Oh,
yeah.
are they?
Yeah. I think this general, this general vibe of it doesn't feel right to kind of take over your body's hormones,
Yeah, right.
that sort of vibe. No, that's still pretty strong in
Yeah, right.
Actually, I think that group of people are much more accepting of HRT, even though it is generally estrogen and progesterone, which is the same stuff that's estrogen and progesterone in the combined pill. But I don't know, it seems to be more accepted. It's interesting. Most of the pills that we have the old estrogens and the old progestogens in them though. So we've got some of the newer ones. So like Zoli, for instance, is estradiol. So that's our normal estrogen hormone. So we're getting there. I think it will end up doing a big switch over, and we will not have to collect mare's urine and take estrogen out of it. I don't know
So
why they're still
when
doing
women
it.
come to you and they say, no, I don't want to take it. I don't want to take hormone replacement
Oh,
therapy.
totally up to them.
Yeah.
Do
Do you try to talk them around? And
I mean, no, my role is not to talk someone into stuff. I think my style of medicine is very much like try and explain what's going on, give you all of the options, pros and cons of stuff, and then you're the boss of that. You can decide. Yeah. I mean, we can say things like, hey, this is protective of cardiovascular health and bone health and, your brain function and aches and pains and how well you feel.
And quality of life, I think, is a big one. The tiny risk you have of developing breast cancer, stroke, any of the side effects, as long as you're a fit, healthy human with the potential benefits that you get from it, weighing up the pros and cons of that, I think.
Yeah.
It's a no-brainer. It should be a no-brainer for most people if they've done the research and listened.
And they've got crazy symptoms.
Yeah.
It can improve the quality a lot.
Yeah.
And I think it's interesting. It's now being accepted as treatment for osteoporosis and preventing osteoporosis, so decreased bone density. Whereas before we knew it had that effect, but we couldn't sort of prescribe it specifically for that. It was only for symptomatic management. And I suspect in the future that there will be more indications as well. You've got a high risk of heart disease in your family and your cholesterol runs a bit high and you're looking a bit metabolic. Well, you're someone who it would be useful to have on estrogen. I mean, that combination too of estrogen and statin cholesterol medication is definitely protective of vascular disease, especially stroke.
I wonder if it's a loss of power. They don't want to take it because they feel, like you kind of said before with the pill, they don't want to take something that's takes away from their own body's autonomy type thing. Do you think?
I don't know. I back, it's been a couple of years now, when I was working, it was a lot of I don't want to put any synthetic things in, but like Lauren was saying, so much of it now is what we call bioidentical hormones. So it's exactly what's in our body. We're just putting it back in.
Clever.
Yeah.
So I'm going to have to correct you on that one.
Oh, sorry.
Body identical.
Body identical, sorry.
Yeah, so bioidentical is something that was really... So that's these compounded troches where they measure your blood levels and then your particular troche is of estrogen, progesterone, testosterone was matched based on that. No evidence behind that. None of the societies and prescribing groups recommend that because there's not... Each combination has not been studied.
Has been studied by itself, yeah.
And I think I can see why that was done in years past, where it was here is this one tablet, or there's this other dosing of it, the second tablet, which is twice of both of them, and like that's it. That's all we've kind of got to choose from. Whereas now you can really titrate it. It's and they are body identical, so it's that it's what your body is already producing.
It's
there.
very clever.
So cool.
Yeah.
And then what about other treatments? Options? What else do we have?
Yep. So it depends what we're looking at symptom wise. So because we see that big serotonin drop, so I think it's drops by about half once you get into that low estrogen state. So that's where we see all of the mood stuff come into things. So certainly for tricky sleep and mood disturbance, we're certainly still using a lot of the antidepressant groups. So SSRIs and SNRIs, which is all of your like Zoloft and like all the stuff I prescribe every day that I can't think of.
All those things.
All of the antidepressant groups. We also use a whole bunch of them for vasomotor symptoms, so the mood symptoms there, which is a bit ironic because a lot of those, escitalopram, that was the one I was thinking of. There you go. Thanks, brain. So a lot of the antidepressant groups, one of the side effects can be sweating.
Oh my God.
It's like one of the therapies for hot flushes and night sweats. And you're like, well, don't know.
This doesn't feel right.
Yeah, it does. It certainly does reduce that. But the sweating is slightly different mechanism there. There's a new medication for hot flushes that works in the brain, in the vasomotor center in the brain, so affecting whether those blood vessels are dilated or not. So that's Vizoa or Fezolinetant or something. I can never remember the real name for it, but anyway, Veoza. And so that is a promising one because it's totally different to hormones. So there's some people who can't have hormones. It's mostly the previous breast cancer and uterine cancer, so it's endometrial cancers and some of the ovarian cancers. So there's not many reasons we can't do it. And at the moment, Veoza is not actually approved in that group, but we'll see. It's just completely different to the hormones, so hopefully there's relief for that. Certainly in terms of I guess that's still hormonal, but in terms of genital symptoms, so the most effective thing for the urogenital symptoms is topical therapies. So we've got several different formulations of topical estrogen, pessary and cream kind of ones, and they're pretty magic for bladder stuff, recurrent UTI, that irritable bladder thing, dryness, irritation, painful sex, that whole group of those, pelvic floor dysfunction. Gets the big, of course. And there's also a new one now that's DHEA. So DHEA is again a hormone that, it's essentially ends up as DHEA, is a hormone that's like a precursor hormone. So it's broken down into estrogen and a little bit of testosterone as well. So it's being touted as, even though it's a topical cream, so you're still putting it, you're still applying it to the genitals, it's being touted as better for libido. With that little bit of testosterone in it.
Does testosterone levels go down or no?
Yeah, gosh, yeah. So, I mean, females have lower testosterone levels anyway, and that can be... Oh, that's one of the symptoms we didn't talk about, libido, but anyway, so that can be a big one. Yep. So so we do have testosterone therapy now for, sexual dysfunction, essentially, hyposexual desire disorder. Anyway, low libido. It's got a fancy name. So we would generally try traditional therapies, the estrogen kind of stuff, and if that's still problematic, have the option to add on testosterone there. But it's not I think over time we will understand more about the role of testosterone around perimenopause, and we'll see. But as for now, it doesn't play a huge role. But yeah, it'll be interesting to see how this DHEA cream, whether that... it's not on PBS, so it's still pretty exy. Got a couple of patients trying it, so we'll see.
Nice.
Watch this space.
Okay.
Interesting. Yeah. And so is it similar to vaginal estrogen? Like, apart from the fact that it's not, is it like used for the same purpose, I guess?
Yes. Yeah. Okay. So it's that genitourinary symptom of menopause.
Okay,
so
cool.
it's all overactive bladder, dryness, irritation, painful sex, recurrent UTIs, pelvic floor dysfunction, that whole group of them there.
Interesting.
Do all of them go together? Or do you just get one?
Often, yes.
Because this sounds really frightening.
Which one would you like to pick, Mandy?
You can pick 5. You can get 5 of them.
So they do like tend to come in little packs.
Yeah.
Little,
But not
like buy one, get 2 free.
So
type
not
thing.
everyone's going to get every symptom. So,
Yeah.
I mean, for things like hot flushes, your classic, like, menopausal symptom.
No, I mean all the
well,
vagina stuff.
well,
Is
I-
this like all like, do you get most of it at the one time?
Yeah, but how affected one person is it compared to the
different.
next
Yeah.
would be different. You know, whether they notice significant, dryness and poor lubrication and pain with sex can be really variable. Like, you can have quite atrophied, fairly dry genitals, but they're quite happy using, lubricants and for that, and that seems to work for them.
So it's not like
Right.
the dryness causes UTI, for example. Like it's not one thing that does the
Sometimes.
next, then does the next. Can be.
Yeah, because you get the tissue. So the role of estrogen in, a lot of tissues, but certainly in the genital region, is that flexibility, so that lovely stretch that it should have, and that great blood flow to it. So having good volume and being able to have good secretions associated with that, so that you tend to get that sort of thinning. Everything becomes a bit smaller physically on the outside. You can certainly
Yeah, that blew my mind. I only found that out the other day.
Yeah.
Remember?
Yeah.
It's like, what?
the body's like, you're done with that.
You don't need this anymore.
Need it. I was like,
You want to have sex? No.
you're finished, lady.
But yeah, like that difficulty with stretch, prone to then getting little tears. And someone with really bad atrophy, like they only have to wipe themselves after having a wee, and they've, it tears the tissue. It can be so delicate.
Me and Becky are like,
But the good news
I will
is,
never be invited back to
if you can tolerate vaginal estrogen, like this is the biggest thing I used to do at work. If you can tolerate vaginal estrogen and it works,
you're fine.
you're not fine, but like it will help to fix a lot of those problems.
You're not fine. Yeah, it's like can be helpful.
Absolutely. Like
Yeah, it makes a
magic.
huge difference. Yeah, it
Yeah.
really
Within
does.
like a week. It's amazing.
Yep. So okay,
Women
so,
rave about it.
Yeah.
Like,
so
absolutely
vaginal
rave.
estrogen is different to the oral or this estrogen.
Yeah, so
Why
systemic
doesn't it
absorption
just
of it.
go everywhere.
Yeah, why don't we? Well, that's true. Like, why do we absorb it through the skin but not through the genitals? I don't know. You got me on that one.
Is it to do with the dosage of it?
Well, it's still like a milligram. I don't know. Maybe the vehicle that it's
Yeah.
associated with. I actually hadn't thought about that. But we know certainly the amount that you absorb through the genitals is essentially not able to be detected systemically. So, for instance,
You have to go there. Yeah, interesting.
yeah, so the systemic therapy, so the patches, creams, tablets, obviously do have estrogen in them that are getting to the genital area, but a lot of women it's not quite enough.
Yep.
Like there's still not. You kind of need that directed therapy right there. And again, for those hormone sensitive tumours, so previous breast cancer or endometrial cancer, most are then considered safe to be able to use that. You've got to talk to your care team about that, surgeon and oncologist and stuff there. But generally,
And
most
then when
are
you
on
say
board.
vaginal estrogen, is that a cream or something?
It can be a cream or a tablet that
And
goes
then when you
in.
said a tablet,
Yeah.
Yeah,
and then
it melts. It's like
Yeah,
waxy.
straight
It
away.
melts.
and then you said if it works for you, what does that mean? Does it not work for some people?
Well, some people it may just not give enough relief,
Okay.
but in my experience, it was like magic.
Yeah. Okay.
And when you say if you can tolerate it,
If you can tolerate it.
Like if you've got no previous history, that excludes you using it. But like Lauren said, it's usually pretty safe in anyone who has that.
Pretty much
private.
everyone.
Yeah.
these
Okay.
days, unless you.
We're good, Bex.
Yeah.
you can tolerate like it burns or something. Like, can you tolerate?
I get some with a bit of irritation. It's pretty unusual though. I think.
Yeah.
I mean, and it's once you've it's every night for a couple of weeks to kind of get you up to level, and then it's only twice a week. So I think most people are all right with that.
Just chuck the old tablet
one,
in.
The Interosa, this new DHEA one, is a nightly one as a long term. So that's a bit more of a pain. But yeah, still options.
Yeah.
Options.
And I think,
So
you
many
get used to
options.
anything. Like,
Yeah.
I use the Contiform for training, and you just get used to it. Just get used to it. Like it felt fucking uncomfortable shoving something up your vagina every day. But now I'm just like, oh, there it goes. You know, you just get used to it.
And it's like that trade-off as well. If it helps you with your symptoms, improves your quality of
exactly.
life, it's worth it long term.
It takes 10 seconds
Yeah.
to get in and out each
Yeah.
day. Just
Yeah.
gotta be in the right place at the right time
Yeah,
with
gotta
clean
remember
hands.
to bring it with you.
You
Yeah.
know, and you're good to go. Yeah, just gotta remember.
Or a bunch of people just leave it in.
Yeah, well, yeah. I just put it in the morning and then just take it out and
Yeah.
I'm good to go.
Yeah. Have you thought about some vaginal estrogen? This is
Wait,
not
I
a
don't need this
consult.
now, do I? What? Not yet. Not yet, Lauren.
No, it's totally fine. No, and we use it. I mean, we use it in other low estrogen states too, like especially after having a baby, like especially if you're breastfeeding, that's a low estrogen state. So, I mean, a lot of what we talk about with these,
Is that why my wrists hurt after I had a baby?
absolutely
Oh.
aches and pains, brain fog, pelvic floor stuff, you know, incontinence and that group of things.
Painful sex.
Yeah,
Oh, I
all
had
of
that
that
too,
dryness, like mood changes, low libido, like a lot of that. I mean, it's the same stuff. It's this low estrogen state where we're seeing it. So,
It's very just constantly rude, isn't it?
and the same kind of stuff we see premenstrually too. So again, all of that, you know, that classic like get a bit unco and feel bloated and irritable at the entire world.
You're going to be a
breathing.
fucking mess.
Jordan already, and we worked out the maths. I'm going to be going through menopause when Callie, my daughter, is going to be like hitting what's called
Teens?
periods. Yeah.
Oh.
Yeah.
And I mean, actually, Candice and I spoke about this a little bit before too. The tricky thing as well is, in the women that present, especially, you know, in 40s and 50s, this is a high pressure time anyway. You know, it's the sandwich generation where classically you've got aging parents on one side and often you have little kids on the other side. You've got often your like peak career, you know, that you've worked up to for 10 years. You're often in a long-term relationship and that's, you know, their hard work as well.
Everybody goes, no.
And so, well, yeah. And so a lot of people coming in, they're like, I'm so tired and I'm angry at the world. And you're like, well, you know, is this hormones? Like, obviously, we're going to look into this. There's standard tests we do for everyone anyway, looking at, you know, is it your thyroid or your low in iron? Like all of those sort of standard screening stuff there. But yeah, a lot of it, I think, interestingly, now that there's more information and understanding about peri and perimenopause, it's actually kind of the opposite. Not this like, oh, I don't want the hormones. I'm actually seeing more of the people coming in that are like, I think this is perimenopause, you know, give me the hormones, thanks. And I mean, given that we know mostly very safe these days to use, I'm pretty open to trialing that. And if that makes a difference, great. But it's this balance of like, is this life? And actually you're just like totally under the pump. And
That's so interesting. And
you
I
know.
think like you say that I guess people just want the quick, not the quick fix, but they just want this magic pill.
Oh yeah.
Whereas I guess the people that we would see, they're very health conscious people that are working out. They're like, don't give me the synthetic things, because that's what I haven't spoke to people, the amount of people that you have about it, but in my experience, people are like, they don't want to take it. So it's pretty interesting the different, different kinds of people with how they feel about it. But that makes a lot of sense. Like lifestyle, situational.
That
Like,
age, just all the things happening.
And, you know, your body in your 40s and your 50s doesn't act like it does when you're 20s. Like recovery is harder
But you're still so strong up here.
right. Probably even more strong.
Yeah.
I think. Like it's a real like
You've built up so much resilience
Go
in your
women.
life. Yeah.
it's really very like go girl, like be yourself. I love this whole vibe that's out now that's like pro women. It's great.
Finally.
Women's
It's
health
about
is
fucking
happening.
time.
Right,
We've only been here for forever.
Yeah.
Thank you for finally studying us, everybody. Thank you.
Actually studying women,
Yeah.
not just extrapolating from like
Hoping for the best.
men and mice.
I read something yesterday. It was like 6% of all studies were done on women or something like that.
Yeah, that makes sense. Yeah, because women have so many more fluctuations, like all of this hormonal stuff there. So
Can't get good
it
data.
makes it
Yeah.
makes it trickier to get data, but also it makes it false data. Well, not for men, but you know that's
Yeah. So what do they
literally
get?
half
Do they
the
get
population.
anything or what? Like all of
it's
this.
like menopause. So they do get
They go
get,
through something.
dropping testosterone levels.
Yep.
Yeah. So it's not an acute event like they're they don't just suddenly stop making testosterone over the course of a year or so. It's this sort of
Slow
gradual decline over time.
And then they just take TRT and they're good to go.
Wow, that can be really problematic.
Really?
So, yeah, in terms of testosterone supplement, I think this is probably an area where there's not as much data to support topping up testosterone, just for kicks, for health benefits, for the strength side of things there, like there is with HRT, MHT in women.
Interesting.
So certainly in this like hypogonadal, so testes aren't producing as much of the testosterone anymore. There's an indication for that, but it's not the same. It's certainly in terms of the range of health benefits that you see in terms of topping up women's hormones.
Is that just the research isn't there yet, or they actually just don't think it's the same?
No, I think because it's that like much slower decline in
okay.
it. So rather than this just like crash, you go from totally high levels to nothing in 2 years, unless there's something medical going on there. It's like men still have testosterone in their 80s.
Yeah.
So,
I don't know if you've seen it or if you're aware, but there's quite a big, I would say, movement on social media at the moment with men's.
Is there?
Yeah, like there's men that I have seen that have quite big followings that are in their mid to late 30s that have tested their levels and then are taking TRT and like promoting the hell out of it. So that it's going to be really interesting to see how that impacts everybody.
Laura's like, fuck this.
Yeah, like
move aside, blokes. Let us have a little bit of light.
Deal with it.
Yeah.
Just for like 5 minutes, could we have some equality?
Just 5. Just the
That's
5.
all we're asking.
Yeah.
Just to try and get slightly close to equal. Like, not even right there.
Chill out, you're fine.
Yeah.
You'll be fine.
Be okay
Yeah,
with your
yeah.
big, strong, powerful muscles. Shut up.
Well, and the tricky thing with testosterone replacement is that because of that feedback loop, then your body naturally produces less, and so then you kind of need more, and then it naturally produces less, and so that's what we see with this sort of abuse of it as well, is in such high levels and everything in the body stops shutting down and stops producing it, and so then you're like, probably not great to be on the roids and get them off it, and then of course they've got this like low testosterone state. It's really tricky.
Yeah,
and of course they feel it's like it gives you the increased muscle strength, and well, they certainly can get the aggro with it, but it's like a very testosterone is a very positive effect. It feels good, you feel stronger, you feel mentally tougher and more on top of things. So I can see how that's abused easily.
Yeah, makes sense.
Anyway,
Back to the girls.
yeah, enough about that.
Enough about those guys.
Anything else you got questions on that?
No, but just to summarize, treatment options. So there's the MHT, which is lots of different ways that you can get that in now.
Yep.
And then we can go for more topical things like the vaginal estrogen, DHEA.
Yep.
Yep. Anything else that you use? And the SSRIs.
Yeah, and Veoza, the new
Yep.
one that we use for hot flashes, so that thermoregulation center in the brain. So certainly in the lifestyle stuff, so keeping physically active, really big one. That helps in terms of a whole bunch of stuff: bone density, muscle density, mood. The more fit you are, the less you tend to be bothered by hot flashes. Whether you actually have less or not
Interesting.
is debatable.
There's
but
a
the less
positive.
body-
Oh.
And then some things like CBT, which is our kind of traditional psychotherapy, can have significant impacts both, again, on hot flushes. So whether that's impact or actually number of them, it's probably more impact on sleep. There's a special type of CBT that really specifically focuses on insomnia.
Is that with
And on
THC or without? Do you know?
So not CBD, CBT, which is cognitive behavioural therapy.
Oh, understood.
Ben is like,
I
oh, this
was
is getting
like-
fun.
I was like, interesting.
Smoking.
Like
Yeah, I was like, are we
So Lauren
gonna
told me to.
are we gonna smoke weed? Is what I'm asking. Lauren. That's where we're at.
So probably not on the traditional list of recommended medications.
Understood.
Yeah. No, sorry, CBT. So cognitive behavioural therapy is the pretty standard psychotherapy technique that we use for lots of stuff. So good evidence for it in terms of mood, hot flushes, and insomnia.
That's so
That's-
interesting.
yeah,
with the
that
hot
is-
flushes.
yeah.
yeah. Yeah, I think it's that like distress tolerance kind of
Yeah,
stuff,
okay.
which is where it affects mood as well. Yeah, whether you're having, because there's plenty of women having hot flashes, and some are like really bothered by it, and others, even, you know, once you start getting them to score stuff, they're like, oh yeah, I'm actually having 15 a day, but just hadn't really noticed
fine,
until I wrote it down.
Yeah, right.
Like so many symptoms in life.
And yeah, I think that's the other thing I assume you would recommend. If you're experiencing any of these symptoms, please go and see your GP
Yeah.
so they can help
cool.
you.
Exactly.
Like, because I think a lot of women just, and Candice and I see this a lot, is they just want to power on and like not give in, you know? So I think it's like,
and we see all
don't have to do that.
Yeah, and all kinds of stuff, like women whose periods just go totally haywire, and they start getting these really long, heavy periods that are, you know, they're having to like schedule their social lives and stuff around whether they can actually leave the house. And
It'd be so good if they went really short and really light.
they can, they do. Then
Okay,
women
so
do
there's
go that
options.
way, and
Okay,
it can
good.
be really variable too. You can have
50-50
like,
backstop.
so there you go. There's a positive.
Maybe.
Potential.
You know, and they're just like ploughing on, going, well, it's just part of it. You're like, actually, you're quite
Doesn't
anemic
have to
and
be,
iron
yeah.
deficient, and we've got options for managing this. And I think, you know, the temptation to have those symptoms and then think, oh yeah, well, this is, you know, just perimenopause, and I can like exercise my way out of that without actually getting it investigated. Like hot flashes can be a red flag for, and night sweats can be a red flag for some nastier stuff like lymphomas and cancers. So, you know, if you're having unusual bleeding, especially bleeding between your periods or bleeding after sex, like they're both two red flags, definitely need to see that. Hot flushes and night sweats, and especially if we're seeing that associated with weight loss, like that's a really worrying one. And easy bruising, like that's another kind of key thing there. So I think even just having that once over, you know, being able to see your GP and you know, rule out some of that important stuff, and have a look at what your general health is like and what things you can change. Like, is there probably a bit much in terms of alcohol? Like, could we look at increasing physical activity? Is there high stress stuff, and how can we delegate that and, you know, be able to give you the space you need for that social interaction and downtime to be able to have good sleep and, you know, all of those kind of tweaks for good health. So there is an available health check called a 45 to 49-year-old health check, and I think that's a really handy time. Like, it's a government one, and it's a top to toe, and it looks at cholesterol and blood pressure and
nice.
physical activity and, you know, all of that lifestyle kind of stuff. And they've done that for good reason, because it's kind of a good time at there to pick up all of that stuff before it starts being problematic. So this is kind of a key in those 40s and 50s. It's like, let's look at health now for the future, and what kind of proactive stuff can we do.
And even earlier, hey, like, I hope the girls in the 30s are listening to this, and like, the healthier you are leading into it.
Oh, I mean, it kind of goes without saying.
Yeah.
But I think it can be easier to be healthy in your, you know, teens, 20s, 30s. Well, easier to choose the option to be healthy than it is as life starts to happen in adulting and all of those like really hard, time-consuming things. So it's a good chance to kind of take that time and reflect on it and have a little snapshot of where you are.
Yeah.
But yeah, I think the key message is symptoms, see a GP, make sure there's not something else going on, and there's heaps of management, like whatever it is symptom-wise going on, we've got lots of management options, lifestyle stuff, non-medication stuff, non-hormonal treatments, heaps of hormonal treatments that are much safer now than they used to be. So, you know,
Don't have to do it alone. Go see your doctor.
Get some help. Are people pretty good? So like the lifestyle stuff, obviously that's something that we focus on a lot here at the gym, and we say the same stuff over and over and over and over again.
With
I can imagine
love and care
with
and
definite
passion.
love, care, and passion. I can imagine you do much the same in the clinic. Like, do people take it on board well, or is it a bit like meh?
With the lifestyle stuff, do you mean?
Yeah. I mean, it depends on how you give it, because I
Yeah.
think you can say, oh, you need to exercise more, as a kind of just standard line, and everyone's like, yeah, of course, like everyone.
Thanks,
knows that.
champ.
Yeah,
Thanks.
yeah. Whereas it can be like, hey, you know, what we're looking at now, we could really do with some more movement in your life. Like, what do you love? What did you used to do? Where can we fit something in? Because saying start running or like go to the gym 3 days a week, you know, there's people who that it just doesn't suit. They're not going to be able to have the time for that, and you just really lose them there. It's like everyone can probably move more. What will work for you? Is it going to be you know, some home fitness thing where you watch a 15-minute YouTube video and do that, where you can just like get in that little bit here and there? Is it going to be something where you need those other people around you in the kind of space like this, and small group classes where you have that support and being able to be consistent with that, because it's just a time you just rock up to that, rather than having to think of something yourself. Like, is it that actually you really love bushwalking, and how can we bring that back in, you know, get you back out in the outdoors?
And then do you
hiking
note that and then follow it up? Do you ask them, did you start training? Do you do that?
I mean, yeah, in a way. And like, I think, you know, same thing with alcohol. You can be like, don't drink alcohol, or, you know, you're drinking too much. And again, that approach of like, okay, so probably more than what we would expect for national standards, and, you know, what does it mean to you, and what kind of drinking are you doing? What sort is it? Is it social stuff? Is it to fill the void, you know, end of the day, fatigue kind of stuff? How do we work around that to, you know, improve health overall? So, yeah, I think the message can be done really, not saying I'm perfect, God, that sounds really conceited now, not at all, but I you know, having that time to be able to actually talk through that stuff, that's the joy of having long appointments.
So that's what you do, long appointments?
Yeah. I mean,
That's
I
so
always
good.
did, and then I ran really
You're
late.
just late.
And now I've changed to my standard appointments are long appointments, because I'm like, that's just my style. I just like to be able to
Get to know people.
understand and really be able to explain.
I think
That's
that makes
good.
such a big difference in
Yeah.
this world as well, because it's such a vulnerable thing to be talking about.
Gosh, yeah.
And like, you want them to be able to open up about, actually, sex is really painful right now, and you know, being able to work through all of that. It's very cool that you've done that.
Yeah. Well, I don't know how else to do it. That's my style.
Yeah.
There's lots of different styles of GPs. You just got to find someone who's your jam that you feel like is you. But you know, we're all different, and everyone else has different needs. I'm sure that a lot of people who have seen me are like, oh my gosh,
you talk so much.
blah, 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 blah. Just want someone who goes, hey, you've got this. Here's the pills. See you in a week.
Yeah.
Oh, well, that's not me. That's different strokes for different folks. Yeah.
Love it.
So, yeah, I think the message about lifestyle stuff is one of the probably longer reaching ones. I think people know, I really could do with getting more veggies in my life. And but then the actual being able to kind of nut it out a bit and go, well, how would we make that happen? What would that look like for you? You know, you hate green leafy veggies. Well, great. I'm not going to say make a salad out of it. Like, what will that look like for you instead? How can we get that in? And that's where, you know, using all of your allied health professionals, all the physios, dietitians, exercise physiologists, love them, for, again, being able to be that support in making sustainable long-term changes. All for that. Yeah,
that's awesome.
That work for you and your, you know, lifestyle and wants and stuff.
So good. Any other questions?
No, I think that's it.
Do you have anything else you'd like to add
know,
from your notes?
I'm going to check
Have a look at your notes.
Wait a minute. Oh, yeah. So I was going to say resource-wise. So if anyone wants to look stuff up, I mean, there's so much now about menopause and perimenopause, and so many podcasts. Ugh.
So many podcasts.
But in terms of really good quality evidence-based resources, the Gene Hale's website.
Nice.
It has all of the women's health stuff, so it's got, you know, stuff about polycystic ovaries and contraception and, you know, periods and all of that side of things, and also significant peri and menopause side of things. But certainly the biggest one would have to be the Australian Menopause Society website, And that's got all kinds of detail for both consumers and for professionals as well, with lots of data. You know, people who want to know the real nitty gritty, like what is my change in stats on breast cancer if I take this? You're like, it's all there. It's
That's
great.
awesome.
Yeah.
And you can Google your area and like find GPs that are listed as a provider.
Yeah, not
as
just GPs,
well.
like other health professionals
Ah,
as well
cool.
can be
Okay.
registered with AMS. Yeah.
So good.
So like pelvic health physios,
Yeah.
for instance,
Yeah.
can be part of that. So, and endocrinologists and gynaes and all of that side of
So
things.
good.
Yeah.
Look at us go, ladies.
So
good. Anything else in your notes?
I don't think there's anything in particular. Oh, there's other, in terms of medication, there's other stuff we can use for bladder specifically, but
Yeah.
nah.
That's awesome.
Nah. Big picture messages here.
No, that's brilliant. Thank you so much for coming to hang out.
That's all right.
I feel like we have our
Share the
own like Dolly
information.
Doctor now.
Dolly Doctor.
Send us your questions and we'll ask Lauren.
Hi, my boyfriend said
Yes. Sealed section. I'm for
We'll
it.
get her back
Oh my God.
twice
She's
a
like,
year.
I'm never coming back.
I remember that. Oh, the sealed. I lived for the sealed
So did
section.
I.
You, no, they were too naughty for me. They were way too naughty. I did not open them. In the
I'd be
fear,
like, what is
No way.
discharge?
no, in the fear that my mum would know that I opened those and then knew stuff. I was like, no, I can't know. This is why you two end up in your jobs about vaginas.
Yep.
And I did not.
Oh,
Yep.
I'm a curious girl.
Nice. Oh, well. Yeah, we don't need to do that. We've got podcasts now.
Yeah.
Just tell the whole world.
Yeah. Yeah. 100%.
Yep.
Cool.
Good.
There's another really cool podcast. I was trying, I don't know how to do that link in somewhere. This one. What? Put the link into this other podcast about menopause.
Becky will just write it across the screen. It's fine.
The
Do your thing.
now
Write it
go. The Imperfects podcast
Oh, yes.
you
did
love
a
those
really
guys.
good one. They've got two now, one on menopause and one on periods.
Yeah, cool.
Where they interviewed
Aren't they two dudes?
the three dudes who interviewed a professor, and it's the best.
So is it? Is that who hosts the podcast? The three guys.
yeah,
right.
yeah.
They got on, I think that was Louise
Newson, yeah. She came back on again last week
Oh, there you
for
go.
a
Didn't know there
periods
was a
one.
second one.
Yeah,
yeah.
it's
So
great.
she's like really passionate about it. She's got a whole own website and app and everything there. She's a British GP who's really passionate about
How
women's
good.
health, especially menopause
Yeah.
and perimenopause. She's very pro HRT and probably slightly more than the like general consensus on it. She's very open to kind of trying it, even with, for instance, previous breast cancer and stuff, where women are like, this is, I just can't, this quality of life is not worth it. There's no point living. And she's certainly more open to that in those kind of groups.
Yeah.
But yeah, great. I really
Yeah,
like
they're
that one.
really good. I'll
thought.
send them to you later.
Yeah.
Love it.
Yeah.
Thank you very much.
Well, thanks for having me on.
very,
I'm
very
excited
much.
to be here.
Yeah, that was really informative. I
Been a
love it.
total brain dump.
Yeah. Anyway. Maybe another one in the future. We'll see.
Sounds good.
Thanks very much. Bye bye.
Cheers.